Welcome to Advanced Practice, the podcast that brews together the latest thinking in mental health practice. Today, we are tackling a topic that shows up in every hallway, every case conference, and every online forum: borderline personality disorder versus bipolar disorder, including the often overlooked ultra rapid cycling mixed bipolar presentation. We will also weave in threads from our content pillars: psychopharmacology, technology and digital psychiatry, clinical pearls and case reflections, professional growth, ethics, law, and integrative lifestyle approaches. So grab your coffee, settle in, and let's untangle these two complex conditions. First, why do BPD and bipolar disorder get tangled together so often? Both can present with intense mood swings, impulsivity, and suicidal ideation. In fast paced clinics, whether inpatient or outpatient, or telepsychiatry, you may only have a few minutes to capture a story, and the surface looks strikingly similar. Add to the fact that many clinicians receive limited exposure to personality disorder diagnostics in school, while bipolar disorder gets heavy coverage in psychopharmacology curriculum. So, the default assumption that any mood unstable patient must be bipolar, which can lead to misdiagnosis, inappropriate medication, and missed therapeutic opportunities. When we compare borderline personality disorder or BPD and bipolar disorder, including the ultra rapid cycling mixed form, the first thing to look at is how quickly moods change and what sets those changes in motion. Speed of mood shift is the clearest divider. In BPD, emotional swings can erupt within minutes or a few hours. A seemingly minor comment, or a partner arriving late, or a text that goes unanswered can launch a cascade of anger, despair, or anxiety that peaks and then subsides almost as fast as it began. By contrast, bipolar episodes, even the ultra rapid cycling variety, last at least a full day. Ultra rapid cycling is defined by having four or more distinct mood episodes, such as mania, hypomania, depression, or mixed states, within a single week. And each episode persists for 24 hours or longer before the next one begins. Next are triggers. Triggers follow a parallel pattern. Borderline personality disorder mood turbulence is reactive. It is tightly linked to interpersonal stressors. Perceived abandonment, criticism, or rejection can instantly destabilize the person's affect. The mood shift is therefore a direct response to an external event. For bipolar disorder, the mood changes are endogenous. They arise from internal neurobiological cycles that operate largely independent of the surrounding environment. Stress can certainly aggravate a bipolar episode, but the core mood swing will occur even in the absence of any obvious external provocation. Finally, the consistency of the pattern. BPD produces a patchwork of reactive, situational mood spikes that come and go with the ebb and flow of relationships. In bipolar disorder, the pattern follows a more predictable cyclical rhythm. Depressive periods gave way to manic or mixed periods, which then transitioned back to depression, repeating over weeks or months. In ultra-rapid cycling, that rhythm compresses into a matter of days, but the underlying cadence, distinct, time-bounded episodes, remains evident. So putting these three dimensions together, speed, trigger, and pattern consistency, gives us a practical mental checklist. If a patient's mood swings are minutes to hours, directly tied to interpersonal events, and appear sporadically, BPD is the more likely diagnosis. And if the swings endure at least a day, occur without clear external prompts, and follow a recurring cycle, We should be leaning toward bipolar disorder and specifically consider ultra rapid cycling mixed presentations when the cycles are exceptionally brisk. A quick clinical pearl. If a patient's affect spikes only after a relational cue, say a partner says, "I'm leaving," think BPD. If the same patient reports a week-long period of racing thoughts, decreased need for sleep, and then a sudden crash into hopelessness without a clear precipitant, bipolar disorder is higher on the differential. Next, the quality of the mood experience. In BPD, mood is predominantly dysphoric, intense irritability, anxiety, or emptiness. True euphoria is rare. Patients often describe feeling on edge or shaky rather than high. In bipolar disorder, including mixed and ultra rapid, the hallmark is mixed affect, simultaneous depressive symptoms like worthlessness, guilt, and then some manic features like racing thoughts, inflated self esteem. Patients may say they feel wired but miserable. This mixed picture is especially salient in ultra rapid cycling mixed bipolar. Because episodes are brief, the patient may swing from a manic like surge of energy straight into a depressive crash within the same day, creating a roller coaster that feels chaotic and unsafe. Recognizing that the manic component exists, even short periods, guides us toward mood stabilizers rather than antidepressant monotherapy, which could exacerbate cycling. Self image and relationships are another discriminating domain. In BPD, identity is unstable. Patients describe feeling empty. They engage in splitting, idealizing someone one moment, devaluing them the next. Fear of abandonment drives frantic efforts to avoid real or imagined loss. In bipolar disorder, self concept remains relatively stable across episodes. While mania can inflate self esteem, it doesn't typically fragment identity. Interpersonal conflict usually stems from impulsive actions such as spending sprees or risky sex rather than chronic relational turbulence. Impulsivity appears in both, but the motivation differs. In BPD, impulsivity is often an emotional regulation strategy, such as self harm to escape unbearable affect. In bipolar disorder, impulsivity is a symptom of activation during manic or mixed states, driven by heightened energy, not necessarily by emotional pain. Suicidal behavior is a red flag in both, yet the pattern varies. In BPD, chronic low grade suicidal ideation and recurrent gestures frequently linked to perceived abandonment. Threats may be used as a communication tool. In bipolar disorder, especially mixed ultra rapid, acute spikes in suicidal intent occur during depressive or mixed episodes. Attempts are often impulsive and can be lethal because the patient's energy level is high. Clinically, this means we must assess intent, means, and how soon they plan to carry it out. A BPD patient may express a wish to die during a relational crisis but lack a concrete plan, whereas a mixed state bipolar disorder patient might have a detailed plan and the capacity to act quickly.